Hello, good evening, and welcome to Endoscopy Now, and the second of our four-part debate series between surgery and endoscopy. I'm Dr. Vivek Kaul from the University of Rochester Medical Center, and it's my great pleasure to co-host this event with Dr. Sri Komanduri from Northwestern University School of Medicine. Sri is a professor of medicine and surgery and the director of the endoscopy unit, as well as associate chief of gastroenterology at Northwestern. Sri and I put together this series expressly for the reason that we've come a long way in the management of foregut diseases, and the collaborative spirit that has been demonstrated across the world, across this country, especially in this realm, is commendable. Now, in terms of the theme for the program itself, let's see if we get the next slide on here. We all know that a major paradigm shift has occurred in diseases that are endosurgically oriented. This four-part webinar series is designed to address each of the seminal areas in the foregut disease management, taking the surgery perspective and introducing the endoscopy perspective as the paradigms have shifted. We will tackle current guidelines, controversies, expert opinion, and of course, share and elucidate the unmet needs. While debates may have winners and losers, the objective here of tonight's debate is to highlight where we were, where we have arrived, and where we might be going in the future. And of course, to highlight the collaborative efforts of GI endoscopists as well as surgeons in the foregut realm. Tonight's theme is novel approaches to GERD therapy, and this is an extremely exciting field that has developed, especially in the last 5 to 7 years, with rapid evolution of innovation, technology, interventions, and techniques in the endoscopic and surgical management of GERD patients, which requires a collaborative approach to decision-making and a customized, innovative solution for each patient. We are extremely pleased and honored to have two fantastic nationally and internationally renowned speakers, both from the surgery and the GI endoscopy realm. Our first speaker will be Dr. John Lipham, and John is the Associate Professor of Clinical Surgery at the USC School of Medicine in LA. He's also the Pamela and James Muzzy Endowed Chair in Surgery and Chief of the Division of Upper GI and Foregut Surgery. Dr. Lipham will be speaking first, providing the surgical perspective on the topic. And then following him, Dr. Ken Chang, who is Executive Director of the H.H. Chow Digestive Disease Center at UCI and Professor and Chief of the division there as well, will be presenting the endoscopic perspective from his talk. Each speaker will speak about 10 to 12 minutes, and then there'll be a mutual rebuttal where they will debate and spar on topics that are important for tonight's debate. After that, Sri and I will moderate the Q&A sessions. These will be questions that will be primarily from the audience and those generated from the panel tonight. So without further ado, I invite Dr. Lipham to start his presentation. Good luck to both of you, and thank you for doing this again tonight.
All righty. Hopefully you can see my screen. If not, hopefully somebody tells me. So I want to thank Vivek and Sri for inviting me to speak. This is really quite an honor to be here with Ken and sparring, so to speak, with him. When I was asked to do this, they said just talk about surgery for GERD, and I really took this as the theme of sort of one-stop shopping. Really, you go to one place, you can get it all done by one person. And so I thought that was me. Here I am, I'm going to talk about what I can do for the GERD patient. And so this complex Netter diagram here just gives you one example of a place to go for one-stop shopping. Before we get into the meat of the matter, though, the most important thing is disclosures. I am a consultant for Ethicon for Thorax, which makes one of the devices that I'm going to be talking about. I think what's probably more important to realize about me anyway is I'm not a consultant for endogastric solutions. The other thing that's interesting and I would think important is, this is difficult for me. I'm a surgeon. We're very sensitive people, very agreeable. really just very compassionate, as I'm sure everybody on this webinar knows. And then lastly, and by no means the least important disclosure, is really that, you know, I always agree sometimes with Ken. And in fact, he's my idol. Some would say there's a bit of a bromance going on here. It probably is one-sided on my side, but I respect him. And so it's difficult for me to argue with Ken. In fact, I think on most things we agree. You know, I think we both agree that GERD is a mechanical problem. I think the only real hesitation over the decades to stop reflux has been really a poor reputation of our one and only surgical option, meaning the Nissen fundoplication. There's been huge safety concerns raised about this procedure. There's questions about its durability. There's huge variations in how the procedure is performed, which results in huge variations in its outcomes. And I think most importantly is the side effect profile. I mean, this procedure has been fraught with side effects, and I think we all know what those are. If you have this procedure done, you're not going to be able to vomit. You're going to be bloated to beat the band, and you're going to be able to actually fly yourself to the moon with the flatulence that's created by this operation. And I think largely this is what's prevented us from sending patients to be considered for any anti-reflux procedure. I think Ken and I can also agree that, you know, the barrier to reflux is more than the lower esophageal sphincter. You know, I think for decades and decades, that's all we've really talked about is the lower esophageal sphincter. But this area is a lot more complex than that. And there is more to this story than just the lower esophageal sphincter. This right here is a publication out of the Cornell group out of New York, who decided to look at this very question: what actually constitutes that barrier to reflux? So when I go in there as a surgeon and I'm going to fix a hiatal hernia, and then I'm going to do either a Nissen or a toupee or even a Lynx, you know, how much does each of those contribute to that newly reconstructed barrier? So what they did is they took 100 consecutive GERD patients, all of which had hiatal hernias. They were all pH positive, and they went in there and did a hiatal hernia repair. And then they either did a Nissen or a toupee or a Lynx. Now, what made this publication really interesting was they used the EndoFlip technology to measure the distensibility index of that newly reconstructed barrier. They did it at various stages of the procedure so they could tease out the contribution to that newly reconstructed barrier from the hernia repair versus whatever I was doing to fix the lower esophageal sphincter. Now, to many people's surprise, what they found was that the hiatal hernia repair actually produced the majority of that change in that newly reconstructed barrier, meaning it was upwards of 80% of that change came from me fixing the hiatal hernia, at least by measurements of distensibility index. About 60% of that new barrier, the length came from me fixing that hiatal hernia. When they looked at comparing Nissen to partial fundoplication to Lynx, all those really contributed equally to that newly reconstructed barrier. And so at the end of the day, they concluded that overall the hiatal hernia accounted for somewhere between 60 to 80% of that newly reconstructed barrier. I think Ken and I can also agree that a partial fundoplication is better than a Nissen fundoplication anyway. This study right here is a meta-analysis. There's been thousands of publications comparing Nissen to partial fundoplication, and obviously in my 12 minutes of speaking here, I don't really have time to go through all those, but luckily these people did the work for me. This was a large meta-analysis looking at 29 randomized controlled trials, upwards of almost 1,900 patients, where they compared Nissen fundoplication to partial fundoplications, and really every partial fundoplication you can think of. And what they found was that the two procedures were equal in efficacy. One of these did not provide any better reflux control, but the partial fundoplications did produce significantly less gas, bloating, and dysphagia. They also had very similar morbidity and reoperation rates. And so at the end of the day, the partial fundoplication did seem to be better, at least from that side effect profile, without compromising anything in reflux control. And so based on all that, I think it's easy for all of us to conclude that really, the barrier to reflux is the lower esophageal sphincter plus the integrity of that crura, meaning not having a hiatal hernia. Part one of the story here to stop reflux has got to be to fix that hiatal hernia. Again, I showed you that paper where it's up to 80% of the barrier is the integrity of that crura. Part two of the story is to fix the lower esophageal sphincter. And here's where we've got a lot of options today. And as Ken may or may not tell you, TIF is actually a pretty damn good procedure to fix the lower esophageal sphincter. It's really an anterior partial fundoplication. And I'll be the first to admit, as surprising as this is going to sound, the TIF does a great job at creating a new valve, a new lower esophageal sphincter. And so if you're following along, and if we use deductive reasoning here, I was a math major, so that's a term that we use frequently for no real apparent reason. But to sort of summarize where I'm coming from, again, the barrier is both the lower esophageal sphincter and the crura. Therefore, all hernias need to be fixed. Therefore, all lower esophageal sphincters need to be fixed. Now, a statement of fact to throw in here in addition to that is nobody wants a Nissen. I mean, if you go to Dr. Google, you're not going to get a Nissen fundoplication because of the gas, the bloat, and everything else. And so therefore, it's plain as day, it's clear as mud. One can conclude everyone should get a C-TIF. They should get their hernia fixed and get a TIF. There you have it. I want to thank you. I rest my case. I will relinquish the podium at this point to Ken.
Thank you, John.
Well, just 1 second. One last thing, if I could, just if you give me just one more minute. I just have one question maybe to throw back at Ken, and maybe it's, why not just fix the lower esophageal sphincter while we're fixing the hiatal hernia? Meaning fix the lower esophageal sphincter surgically. And so maybe, just maybe, I don't know for sure, but maybe there's an alternative to the Nissen fundoplication. And I think there's where we've got some new things out there that might, just might, be as good as TIF, such as the Lynx device, which is represented there on the top right, or even some newer surgical partial fundoplications. And so the question becomes, well, is Lynx really any better than Nissen fundoplication? Well, this question actually has been answered. This right here is a meta-analysis from Luigi Bonavita out of Italy, who looked at 7 different studies. Follow-up was out to about a year, and it wasn't a small study, upwards of 1,200 patients, where he compared Lynx to Nissen fundoplication. And what he found was that the two procedures were very similar in symptom relief, meaning GERD HRQL scores and PPI elimination rates. They also had very similar dysphagia rates. But where Lynx really shined was that it had significantly less gas and bloating and a much higher likelihood of being able to belch and vomit if need be. Now, the skeptics will tell you, well, this is new. It's only been around for 12, 13 years. They don't have any long-term results. It's not going to last. Well, Luigi Bonavino also published his long-term results on the Lynx. 124 patients that he followed for 6 to 12 years post-op. In fact, the mean follow-up in this group was upwards of 9 years. And what he found was that it was a very durable procedure. At the 9-year mark, percent time pH less than 4 had decreased and stayed decreased down to about 4.2%. Overall, there was about an 80% pH normalization rate at the 10-year mark. GERD HRQL scores at 10 years were still good at 4.0, 93% patient satisfaction. Regurgitation all but disappeared in this group, and almost 80% of patients were off their PPIs. So again, a very successful and durable procedure with now follow-up out to about 9 years. What's interesting was that the hiatal hernia recurrence rate in this group was only about 6%. which if you follow the Nissen literature, you'll find that at about the 10-year mark, the recurrence rate of those hiatal hernias is upwards of about 30%. So the links seem to have a significantly lower recurrence rate of the hiatal hernias and recurrence rate of reflux. Which this leads us to the next question. Well, what if I'm a patient and I just don't want one of these little metal thingies in me? That just doesn't sound very attractive. What about a partial fundoplication? And so it begs the question, does a partial fundoplication truly have less gas and bloating? And really, to answer this question, what we need here is really a study that's dedicated just to the study of flatulence after anti-reflux procedures. I mean, that would be the holy grail. If we could have a study that was dedicated to flatulence, I think we'd have the answer to the million-dollar question. So knowing I'd be up here against Ken, I figure I really had to pull out all the stops in order to try to convince you that my one-stop shop is the way to go. So, I mean, I combed everywhere looking for the answer to this question. So I read all the major textbooks that I could find that had anything to do with flatulence. I consulted with some of the most famous people that have had flatulence problems over their life. And of course, I also went to Dr. Google, just like we all do, and found a pretty reliable website that was dedicated in this article on flatulence. It turned out it was a weird subset of flatulence that didn't really apply here. But I stumbled across, after this particular website, on a publication that was dedicated to the study of flatulence. It was called the Flatulence After Anti-Reflux Treatment Study. This was from Dave Watson's group out of Australia. It was coined the FART study for I'm not sure what reason. Not a small study by any stretch of the imagination. Over 260 patients, 11-year median follow-up, and they looked specifically at the gas issues, comparing Nissen to various types of partial fundoplication. And it should be no surprise what they found at the end of the day was that the Nissen indeed produced about 3 times more flatulence issues than really any of the partial fundoplications. Now, I have no idea how they measured that, what sort of special measuring device that they had, but at the end of the day, they confidently concluded that the partial fundoplication had much less side effects. And so that leads us to sort of the newer procedure that we've been doing here in the United States called the Watson fundoplication. This isn't all that new. It's been around for about 10 years out in Australia, but hasn't caught on till recently here in the US. And what this is really a surgical TIF, in my opinion. It's an anterior 180 degree to 270 degree wrap. That's what's illustrated right here on the laparoscopic picture that you see on the sort of the top right. The endoscopic image is what it looks like after reconstruction, after the Watson on retroflex view. And you can see it looks like a pretty good valve. And in fact, I would say it looks very similar almost to a TIF. This right here is Dave Watson's publication out of Australia looking at the 1- and 5-year results of Watson fundoplication. So they looked at 5 different randomized controlled trials. And at the 1-year mark, what they found was that the Watson fundoplication had significantly less dysphagia as well as gas, bloat, flatulence, but very similar pH or reflux control compared to Nissen fundoplication. They also looked at the 5-year results, and again, the partial or Watson fundoplication compared to Nissen had significantly less side effects and pretty much equal reflux control. And so at the end of the day, I'll sort of kind of wrap it up here to try to make my case. First and foremost, the hiatal hernias, they need to be repaired, all of them. Secondly, we do have some more palatable surgical options for the treatment of this disease, links and partial fundoplication being 2 of the best. They do produce less dysphagia, less gas and bloat with equal reflux control. I will fully admit before Ken gets on here, I think the TIF does a great job at recreating that valve. And so really at the end of the day, this idea that we can go to a one-stop shop and one person for all our needs may sound attractive, to go to one guy to get your bankruptcy or divorce and liquor yourself up sounds kind of interesting, but at the end of the day, I don't think it's best for the patients. The bottom line is we have a lot of options beyond PPIs, and I think it's going to take collaboration between GIs and surgeons to determine what's the best treatment. So anyway, with that, having said that, I will relinquish the floor to the good Dr. Chang.
Thanks, John. That was wonderful, and I was really surprised that you were relinquishing it midway. So, Ken, you're on, and I think he's made a great case for the anatomy and for the hernia, and you get to go in support of the LES. Thank you again.
Thanks, Vivek. Thanks, Sri. Can you guys hear me okay?
Perfect.
Okay. Boy, John, it's always hard to follow you. We've shared podiums multiple times. I always am sad if I'm second to follow your great humor and wisdom and cartoons, but I'll do my best. These are my disclosures, but the biggest disclosure, John, is the bromance is actually mutual. I've always admired you. You've been a friend, a colleague for many years, and we were able to be a part of the A team together, and that's AFS. So we invite everyone to join the movement. Very much like AFS, my environment is not one of just GI, and the collaborative theme I think is so paramount for AFS, paramount for the whole GERD space. And this is our Forget team here at UCI's Digestive Health Institute. So we have interventional GI, we have GI motility esophagologists, we have world-class Forget bariatric surgeons, as well as GI esophageal oncology, as well as an ENT. So from the beginning of our institute, we've always been collaborating, and GERD is at the premiere of our example of how collaboration raises all boats. When we started including a lot of the endoscopic components, the number of GERD anti-reflux surgeries more than tripled in our institution. So there's no competition because the tide raises all boats. So the key points to my 11 and a half remaining minutes is there are many, many GERD patients who are refractory to PPI, who are appropriate candidates, but are not receiving anti-reflux surgery or procedures. And the personalized approach to the GERD patient includes a thorough understanding of the anatomic alterations, which John already alluded to. And there are many, many good options for anti-reflux surgery and procedures, including endoscopic therapy, either alone or in combination with surgery. And GIs and surgeons really do need to work together, because then everyone wins. Most importantly, the patient wins. I'll be talking about the 3 endoscopic devices on the top, which are FDA approved. The other 2 are approved in Europe on the bottom, but not yet in the States. So here are some interesting trends. So I'm looking at it from a really big picture, a macro picture of GERD. And if we look at the number of anti-reflux operations performed in the US from 2005 to 2010, in the red are the laparoscopic, in the blue are combined procedures, anti-reflux procedures, and they are all less than 20,000, and it's continued to this day. Roughly less than 20,000 anti-reflux surgeries are performed annually in the United States. Well, what's the need? And is there an unmet need? And the answer is a resounding yes. This recent survey in Gastro, 71,000 people were interviewed, and it turns out that 70% of the US adults have GERD. That's about 80 million. 35% of them are on meds. 55% are on PPIs. That's 15.4 million. 68% of PPI users take it every day. That's 10.5 million. 54% of the daily PPI users are refractory. By strict definition, they have persistent, troublesome symptoms despite single or double dose PPI greater than 2 days out of the week. So that amounts to 5.6 million people. So now you can also do the math. You have 5.6 million people who are candidates for a great endoscopic or surgical procedure, yet only 20,000 anti-reflux procedures are done annually. That is a huge unmet need, less than 0.4%. So we really do need to change the GERD conversation. We need to stop talking about which surgery is better, Dor, Toupet, Watson, which endoscopic is better. That's merely moving the furniture around the room. We need to bring more furniture in the house. And that is, how do we provide more effective therapy to more patients? And this is the similar argument that the bariatric surgeons have shifted to, resulting in a dramatic rise in the number of bariatric procedures. So we need to agree more than we need to disagree. What we definitely agree on, both John and I, is the anatomic assessment is crucial. There are 3 components. There's the LES, there's the vertical hernia, and there's the almighty, all-important diaphragmatic crura, which speaks to the width of the opening of the diaphragm. And it's a dynamic process. The crura is crucial. Even without the presence of a hiatal hernia, the crura is dynamic. It works synchronously with the LES. It allows for venting and burping, and it changes the angle of the G junction, very much like the pupil rectalis does on the other end. And this I learned from John in one of his early lectures. So the diaphragm is critical. The problem is, how do you assess the function of a diaphragm when your upper GI series does not show a hiatal hernia? It's all on the endoscopist. So endoscopy is crucial for determining the anatomic defects in the patient with GERD. So here's an example of an endoscopy. It looks like the G junction looks fine. You retroflex, it looks like a Hill 1. You blow some air, and then things move around a little bit, and now it seems like the diaphragmatic pinch is lower than the gastric fold, and you do a retroflex view, and it looks like a different patient. This impression that you see here, that is the crura of the diaphragm opening up. That is a Hill grade 3, and at the time of surgery, this is what the surgeon will see, this open diaphragmatic hiatus. This is about 3 by 2 centimeters. And that is what you're seeing on the retroflex view. So endoscopy is critically important, and arguably the only thing that really can sort out these patients who don't have a vertical hernia, but need a crural repair and need our surgeons to come in and help us with this anti-reflux procedure. So that is a very important component that we as gastroenterologists are just starting to appreciate and learn how to assess for the Hill grade and be able to categorize and risk stratify these patients appropriately. Now, the LES is the domain of the potentially of the GI endoscopist in terms of assessing and even fixing. And we're just, again, starting to learn of the intricacies of the EGJ flap valve. Indeed, it's the lower esophageal sphincter, but did you know that these circular muscles of the lower esophageal sphincter actually extend and are part of the gastric sling fibers? And when this muscle contracts, it acts as a swinging door, swinging that greater curve angle towards the lesser curve backstop. So here on retroflex view, this little lip here, that is formed by the gastric sling fibers. And so that's the sling fibers oriented. So when it contracts, it's actually swinging the valve closed from the greater curve towards the lesser curve. And I can flip that around for you so you can see the purple sling fibers here and on the diagram. So the EG junction flap valve is not just a sphincter that opens and closes like the anal canal, but it's actually a true flap valve. It's a valve because it flops closed and open. It allows for venting, but it doesn't allow fluid and solids to go up in the esophagus, because fluid coming up would more likely close the valve rather than get up into the valve. So length is important, diameter is important, but the floppiness of that flap valve is very important. And a lot of that flap valve reconstruction needs to be taken into account when we talk about all of the various options for fundoplication, partial fundoplication, and TIF. So the ideal flap valve reconstruction is going from the left hand picture where there's no flap valve, there's no angle of His. Now there's no hernia, right? The diaphragm is fine, but there's a complete destruction of the native flap valve. In order to recreate the flap valve, you need something that creates length, intra-abdominal length, something that creates narrowing, but not too narrow, and something that is floppy, so that when fluid hits the side of the valve, it'll close it from greater curve to lesser curve and restore the natural physiology. So what technique, what device can create this ideal flap valve? So here is a picture of a retroflex view of a flap valve that's rather short. The angle of His is rather flat. And the next picture I'm going to show you is a reconstructed flap valve. So you say, that's a nice flap valve, right? It's long, it's uniform, it's floppy, it's narrow, but not super tight. And that is what we typically can do for a patient with the TIF procedure. Whether the TIF is done by a GI endoscopist or by a surgeon, this is reproducible, scalable, and once you learn it, everyone can make a valve like this. The surgeons will say that their partial fundoplication is different from surgeon to surgeon, and even the same surgeon on a given week, depending on how much coffee they have, the flap valve may look a little bit different. And the two valves are deeply, deeply integrated. What does that mean? Look at the door. The door is the flap valve. The door frame is the G junction, is the diaphragm. You can make a beautiful door, but that door frame is crooked and bent and too wide. That door won't close properly. The other way around is true also. So you need to have a door and a door frame that fits together beautifully. And when they fit together beautifully, then they both work and they both are synergistic with each other. So we need to keep thinking about the two combined. And if the surgeons can do the door and the door frame, great. If the GI can do the door and the surgeon can do the door frame, great. We just need to get the patients to that right combination and anatomically appropriate. So endoscopy is key in assessing GERD anatomy and physiology. So this is the message to the surgeons, because the surgeons have looked at the valve from the serosal side for years and years. We as endoscopists have looked at the flap valve from the inside. We need to think about how the surgeon sees things on the crural side. The surgeons need to see what we see on the endoscopy side. So on the endoscopy, it's critical that we all assess the LES, including the flap valve, which is the gastric sling fibers portion of the LES. Obviously, the length of the hernia, we're all good at that. As GI endoscopists, we're terrible at the Hill grade. We are really bad at even putting it in our endo reports, but we should take 60 seconds out of our exam, inflate the stomach with CO2, and try to elicit that open diaphragmatic hiatus, which then will send the patient for a laparoscopic repair. We need to assess for the presence of esophagitis. And then we do a pH study. Upright versus supine reflux can be delineated with the wireless pH assessment. We do esophageal manometry on select patients. And many of us are now doing endoflip on a lot of our GERD patients in more or less a preoperative type of protocol. So you see that endoscopy is key to assessing GERD anatomy and physiology, and endoscopy is now front and center in taking care of the GERD patients diagnostically, risk stratification, and anatomically putting the patient into the right bucket, so to speak. And now endoscopically also of being able to reconstruct the LES flap valve. So now we look at the anti-reflux procedure options as a totality. If the patient has a hiatal hernia or a Hill grade 3, they absolutely need a hernia repair. They need the hernia to be reduced and the crus to be repaired. That is a lesson, a hard lesson learned for me. It took me 10 years to really appreciate that actually the vast majority of GERD patients need a hernia repair. And in our TIF population, we are now, I would say, 80% C-TIF versus 20% TIF alone, because we've learned to appreciate the vast majority of patients have a defective crura as well as a defective LES. Then we get to the LES flap valve, and as John has said, there are many, many great options. You can do a Nissen or a partial fundoplication. You can do the links. You can do a TIF. You can also do a gastric plications. And there are situations where a gastric plication is really the only option. Say a patient who's had an esophagectomy, or a patient who's had a very tight sleeve gastrectomy, and they have bad GERD. So then a gastric plication is appropriate, and these are endoscopic procedures. So there's the mucosal ablation and suturing procedure called MAZE. That involves ablating the mucosa and then using the overstitch device to create a gastroplication. There's also the resection and plication procedure called WRAP, where we do a wide field EMR on the gastric side of the GE junction, and then we suture in the zigzag pattern, creating both shortening and narrowing of the GE junction on the gastric side. And this is very good for patients even after a gastric bypass. And there's a pouch, but a lot of reflux. We can do the WRAP procedure. We can also decrease the compliance of the sling fibers. The flap valve sling fibers, if you make them stiffer, they're less likely to efface and less likely to trigger a transient LES relaxation. So that's the strategy behind the Stretta procedure, as well as the strategy of the anti-reflux mucosectomy or ARMS procedure. So talking about TIF, which is transoral incisionless fundoplication, this has really revolutionized the endoscopic approach to recreating the LES flap valve. And it's a device that goes in endoscopically, it's retroflexed, and you can create this beautiful 270 to 300 degree partial fundoplication, lengthwise 3 centimeters, max 4 centimeters. Now, moving on to the case of the sliding hernia or the open diaphragmatic hiatus, there are a number of options, as John said. You can do a Nissen or a partial, you can do a LINX, or you can do the C-TIF, the concomitant laparoscopic hernia repair plus TIF. And the question always is, well, why would you do that? In 20 more minutes, I can do, this is the surgeon speaking, I can finish with a partial fundoplication. So why go through the hassle of yet another device? So this is an example of a patient before their hernia repair. And this is the intraoperative appearance. And this is me working with Ninh Nguyen, our chair of surgery. And here, Ninh is identifying the large crural defect, and he repairs it beautifully, but there's no flap valve yet. So then I come in. So Ninh takes about 40 minutes. I take about 35. No, we're about the same. We're not competitive. Then I come in and I do the TIF, and now the flap valve is done, and the patient goes home with the door and the door frame perfectly matched. This is the evidence looking at TIF 2.0 versus standard anti-reflux surgery, both the TIF and the C-TIF. But as was discussed, the side effects, the gas, bloat, dysphagia, and so on, is significantly less than the traditional Nissen fundoplication. So I'm getting towards the end. I know I'm about 13 minutes or more out. So this is a paper that Nin wrote with me. Collaboration between GI surgery and gastroenterology improves understanding of the optimal anti-reflux valve, the omega flap valve. So basically, from doing hundreds of cases together, Nin and I started to really learn from each other. I began to learn the importance of the diaphragm. He began to learn the importance of the flap valve. But day after day, he would be looking at the endoscopic flap valve and thinking to himself, gee, I can do that. So this is also the same idea, John, of doing the surgical TIF. But my point is that as surgeons, we need to look at our flap valve. This is a, Nissen that's a little bit tight and a little bit twisted. And so when you look at that, you shouldn't be happy, right? You should be looking at something like this that is straight and doesn't have pinch points, just like you showed, John, with your Watson Fundo, a beautiful valve that's partial, that's long, and that's uniform. So I think the lesson learned is as we collaborate, we can challenge each other, but we could also push each other to make it better and better. And one day it may be that as a joint effort, we have 5 different options for people on different parts of the GERD anatomy spectrum. Some will be surgical only, some will be combined, some will be endoscopy only. But if we can provide that best solution, minimal side effects, and those 5.6 million people started getting the treatment that they needed, then it's a win for everybody. So there are some home run indications where endoscopic treatment is really the only option. Like after a POEM procedure, we can do a TIF. After esophagectomy, we can do a maze or wrap. After a sleeve, we can do links, maze, wrap, or arms. After failed fundo, when no hernia repaired, we can do a TIF. But the main point here is GIs and surgeons need to work together. Everyone wins, especially the patient. And with that, I thank you and feel free to email me. Thanks again for listening.
Thank you, Ken. Again, an amazingly insightful lecture. So John, you and Ken are now at each other. John, do you have any pressing rebuttal or question for Ken? And then Ken will have at you as well.
No, I guess the only thing I'll throw back at Ken is just the question about assessing the integrity of the crura. I think that's where all of us struggle the most. And so I agree with you. I think, if we knew that the crura were fine, there were no issues with it, and definitely there wasn't a hernia there, then fixing the LES is probably all that patient needs. But therein lies the difficulty. There's some good data from actually Shree's group, John Pandolfino and them, that looked at a group of patients where they didn't think there was really any hernia, did 3D high resolution manometry and stuff, and found that the crura were still defective as far as their contribution to that barrier, even though the patient didn't have a hernia. So how can we be confident that the crura aren't a problem or won't become a problem down the road?
Great question, John. You said in a prior lecture, and it resonates in my mind on a daily basis. You said any person who has pathologic GERD has an abnormal crura and needs a crura repair. And initially when I heard it, I was like, that's too out there. And over time, I'm thinking, I think there's a lot of truth to it. I don't know if I'm 100% in agreement yet, but getting there, because time and time again, we're identifying patients who initially we think, oh, the crura is fine, but it's not. So I don't think it's every patient, but I think it's the vast majority, John, that have a defective crura. Our job is to at least identify the patients who have an obvious crural defect and get them to the right appropriate treatment. And minimize the numbers of patients who, you do a TIF alone on, and 6 months later, they have a sliding hernia, and you say, oh, I should have done a laparoscopic hernia repair first, or in combination. I will say though that there are patients that do respond to TIF alone, and there are patients that I iatrogenically, i.e., we do a poem myotomy and we cut the LES, and their Cura is fine, right? We made the Cura defective, and we fixed we made the LES defective. We fixed the LES with TIF, and they do great. But does that happen out in nature? Do people get defective LESs and have a pristine diaphragm? I don't know. I think that there is that category. We have patients who just get the TIF alone, and they do well for years and years, 5-10 years out. So there are those patients. I think. So I'm not ready to say 100%, John, but it's moving in that direction.
All right, Ken, you have something for John? Anything you didn't like?
Yeah. So I think, I mean, this is, again, the main theme is all of these procedures, many of these procedures are great. But I think maybe the holy grail, John, is, do you think as surgeons, you've got a hernia repair that is bulletproof? Because they keep failing. I mean, we keep seeing failures, and the failures are typically, well, once the Cura gives out, right? No matter what beautiful valve you put in there, what beautiful door you put in there, the valve gets mangled when the Cura opens up. So tell me from a surgeon's point of view, is there an unmet need in getting that Cura repair perfect?
Yeah, it's interesting. You're absolutely right. First of all, and I love that door jam door analogy, because that's exactly what it is. And none of these anti-reflux procedures work if the door jam is out of cockeyed or whatever. You're also right that this is the Achilles heel of all the anti-reflux procedures, no matter what we're talking about. A Nissen doesn't come undone. It doesn't come unwrapped. That's what we classically were taught. What happens is the hernias recur. And once the hernia recurs, the reflux comes back across the board. Same thing for links, same thing for C-TIF, same thing for everything. So the problem is finding a way to better fix the hiatal hernia so it's more durable. I think for the last 30 years, we've spent all our time and energy on looking at better ways to fix the LES when that's not what we really needed. So currently we're starting a randomized controlled trial looking at actually injecting platelet-rich plasma into the Cura at the time of repair. And the reason we're doing that is because there's quite a bit of evidence to suggest that the PRP will bring in a lot more of the growth factors and healing that we need, specifically collagen, which seems to be the defect on why these patients developed hiatal hernias to begin with. But right now, we don't have the answer. 30% of these procedures are going to fail because of a recurrent hernia. And until we fix that, nothing's going to be durable for life.
Exactly. I mean, we have to think of GERD as almost a myopathy.
I agree. I mean, we tell patients, it's a genetic issue. It's probably collagen or something similar. And until we figure out a way to correct that, as a surgeon, I can take that crappy Cura and I can sew that crappy Cura back together, but you sew crappy tissue back together and guess what? Well, it's still crappy and it's going to come undone eventually, and then hernias come back.
Excellent. Thank you, guys. So we're going to, I think these talks and the discussion has been so powerful that, we're down to our last 10 minutes. And these guys have been too nice to each other. So we'll see if we can stir up some anger. Just to start it off, and then we'll try to keep succinct on these because I want to get through all the questions. A lot of people are chiming in, and if we have to, we'll get to a rapid fire here at the end. Can you just both comment? Ken, you brought the analogy that we got to get more furniture in the room, and anytime you get more furniture in the room, more people want to sit in the furniture. Mm-hmm. And so my question to both of you on both sides is, what is that? Are there metrics from a quality perspective? How do we know that we're doing a good job? Who's a good endoscopist doing TIF, and who's a good surgeon doing hernia repair, links, anything? Are there volumes? Are there specific metrics that we need to be held to moving forward? If this 0.4% goes to 20%, how do we know we're doing a good job? And maybe start with you, Ken.
Yeah, I think we're at our infancy. You know, the work that you guys have been doing and University of Colorado looking at quality for endoscopic eradication therapy, and that is what we need to do in the GERD space as well for endoscopists. A GERD assessment, how to assess patients with GERD appropriately. We're terrible at it. We're terrible at it. Never mind treatment, but just even assessment, we're terrible at it.
John?
We're worse as surgeons. I mean, I can tell you, you come out with any sort of surgical diploma and you're allowed to do any anti-reflux procedure, any foregut procedure on earth. So one of the reasons we started up the American Foregut Society was to push the envelope forward to try to get fellowship specialization in foregut. So not every Tom, Dick, and Harry was allowed to do whatever they wanted to the esophagus. We've had some success. This year is the first year that we do have an accredited foregut fellowship. And so I think down the road, we will now have specialists, surgical specialists for doing these procedures. There's plenty of literature and data to suggest, at least as a surgeon, you need to be doing about 25 hiatal hernia, paraesophageal hernia, GERD surgeries per year to be competent. But in reality, that's not what's happening. There's people out there doing 2 a year. They'll do a third one,
I think that's a great takeaway. Maybe something for the AFS to tackle. Real quick, maybe a quick one for you. John, you tackled this in the chat. Someone else has asked about a comparison between Watson and Toupet. Has that ever been looked at?
It has, in smaller studies. So basically, for those who don't know, a Toupet is about somewhere between 180 to 270 degree posterior wrap. So in order to do it, we have to take down the short gastric vessels and we wrap it around. The Watson is pretty much the reverse. So now we're doing 180 to 270 degree anterior wrap. The difference is we don't have to take the short gastric vessels down. We don't have to take that blood supply to the stomach. Most studies have shown that the two procedures are pretty equal, or very equal in reflux control. My personal opinion, my experience is that Toupet creates a little bit more gas and bloating, and that may be due to taking the short gastric vessels down, because there's been many studies that have linked some of the gas and bloating to ligating those blood vessels to the stomach. So short answer is they're pretty equal. I think the Toupet's got a little bit more side effects, but not like the Nissen.
Excellent. Real quick, Ken, you alluded to about 20% of your patients just get a garden variety TIF without hernia repair. That's intuitively patients who have absolutely no hiatal hernia, or is there some other category there that you're talking about?
Yeah, so that would also include post-POEM, right? But the GERD patient walking in the door after a thorough assessment, and they have a rock solid Hill 1-2, no sliding hernia, and if they have LAC or D esophagitis, then I'll still go to surgery. So if they have a smaller acid burden and they have the appropriate anatomy, then I'll do a TIF alone.
A question came through, and I'm not sure I'll leave this for you guys to translate a little bit. That has there been any reports on combination of TIF and laparoscopic cruroplasty?
I think they're just getting to, I mean, technically that would mean fixing the hiatal hernia and doing a TIF, which is the C-TIF, which I'll defer to Ken on that.
Yeah. So what we don't want is to anchor the stomach to the crura before doing the TIF, because then the TIF can't pull, can't rotate. So that would be the only difference.
Yeah, I think the randomized trial is currently underway. It's going to probably last about 3 or 4 years, but that's for the C-TIF versus the standard interventions. So
yeah,
C
it's versus Nissen.
Missing,
That's,
right,
yeah.
right, right.
Can we
Uh,
touch on one more thing here as we get close to the end? Just there's been a question on the surgical side, and maybe we both just around reimbursement, and maybe we can touch on this important piece from both of you. The surgical question was, do you have an issue with payers when you refer to it as a hiatal hernia repair? And maybe John, you can comment quickly, and then Ken, maybe just a quick summary of where we are with reimbursement with TIF.
Yeah, well, therein lies the problem we have with the coding system that we have. The CPT code doesn't really have a code for a hiatal hernia repair. It has a code for fundoplication, which includes cruroplasty. And then the only other code that we have is for a paraesophageal hernia repair. Technically, a paraesophageal hernia is when a vast majority of the stomach is herniating up above the LES and into the chest, not a sliding hiatal hernia. So it gets down to a little bit of a moral and ethical debate on when you use the paraesophageal hernia code to code for a sliding hiatal hernia repair. Because again, that code doesn't exist. So we're a little handcuffed right now with the coding system the way it is.
All right, this is great. So we learned a lot. We learned that the repair of the hernia is critical. And we also learned that beyond TIF, there are also a lot of mucosal ablation and suturing options. So I think those are great. In the rapid fire section, which we have only a couple of minutes, Ken, learning curve for TIF, how many cases?
I would say 5 to 10 cases to feel somewhat confident, probably another 20 cases to feel very good.
Problem with reimbursement in your area, at least?
TIF alone, Medicare reimburses in every state in the country, but a lot of the private insurances like the Blues don't cover it, and that could be an issue here in California.
Should be an upfront discussion. John, learning curve for links?
Virtually no learning curve for links. It's all with the hiatal hernia repair, which that learning curve to me is about 25 to 50 minimum before a surgeon's competent.
Sounds good. Ken, major serious complications or catastrophic complications that you're aware of or that you can tell the audience from TIF and any other similar endoscopic ablation, anti-reflux surgery operation?
Yeah, extremely safe procedure. I think the overall complication rate is less than 0.035 or something. But early on, there were reports of pneumothorax, esophageal perforations. But I think that was early on in the beginning years.
Right. And John, anything serious on your end from a routine, procedure that almost same day discharge? Anything that you can share that you've seen or you've heard of?
Well, the main thing with links anyway is the risk of erosion. That's something we worried about going into the clinical trials. Fast forward to where we are today, and that erosion rate, because the device is dynamic, is only 0.3%. When it eroded, we just removed the device. We didn't have to do anything more major.
All right. Ken, endoflip, yes or no?
Well,
Sorry.
yes, endoflip is part of every GERD workup, essentially, especially because if they're going for a laparoscopic hernia repair, the surgeons either will ask for a manometry or an endoflip to rule out achalasia, because they don't want to do, obviously, an anti-reflux in an achalasia patient.
Right. And John, endoflip for you? Every case? Some cases?
Absolutely. I love endoflip.
Final rapid fire question. Who wants the redo cases the most, John or Ken?
I'll send them to Ken.
All right, smart man, John. Sri, back to you. Thank you for the rapid fire.
I'm going to wrap up here, and for the sake of the debate here, the poll of the evening has popped up, and don't pick your favorite friend, but who won tonight's live debate? And wow, this is good. This is a tight race. I almost feel like it's like a horse race here.
Wow.
As we see this live, it's kicking up here, and it's
now, wasn't the audience 90% GI? Let's be clear.
No, that was the previous one. We moved on.
Right.
No, foregut surgery is way more common than esophageal cancer surgery. So,
so as this kind of comes up, and this is all in fun, and I think I want to thank Ken and John for being here. Every time you do this, it's a great learning experience for me, and you really have brought two fantastic lectures and debate, and I love the conversation. I think we're all better off for it. It really does kind of bring together the GI surgical collaboration that's needed, especially in such a common disorder. I think that's fantastic. It highlights what the AFS is really all about and what you guys have brought together with that organization as well. And I think on the part of Endoscopy Now, it's great to partner with an organization like this and bring an event like this. Is a ton of fun. So thank you both for taking the time. For everyone else, thank you for joining us. That does conclude the debate and the Q&A. We have 2 more coming up in the sequential weeks of September 7th and 14th, so you can register through the app and join us for those. As you see, Dr. Chang doubled up here on Dr. Lipham to end our results.
I think this calls. Wait, I think this calls for a rematch during stages, John.
It might be a different outcome. John, well tried, well tried. Thank you so much, both of you.
All right.
Nice.
Thanks, everybody.
Thanks everyone for joining.
Great, great event.